Hello everyone, welcome to another lecture, and today we'll discuss something about central nervous system infection, specifically meningitis. So before we begin, I would like to request you to like, share and subscribe to the channel if you like the content in order to encourage me, and we'll begin with the lecture. So meningitis. So meningitis is the inflammation of meninges surrounding the brain and it is a life-threatening complication. So you need to recognize the common signs and symptoms of the patients of meningitis. So what are the common clinical features of meningitis? They are headache, nausea, vomiting, restlessness, photophobia, and variable consciousness, seizures. And if you see for the signs, then you find various signs like Kernick signs, Brudzinski signs, neck rigidity, nuchal rigidity, and there are focal neurological deficits. There is obdentation, there is spasm of the neck, and there is extremely high grade fever. So these are the common features of meningitis along all types of meningitis, and you have to keep all this in your mind when you see a patient and you suspect him of being meningitis. So what are the CSF findings? What are the CSF findings in various kinds of meningitis? You might have seen this table time and again, and I'll also repeat it in front of you. So BC pressure, BC WBC, BC protein, and VC glucose. Okay, so normally what is the pressure that we consider? That is 28. All this pressure is in centimeter of mercury. So you have to remember this centimeter of water, not in millimeter of mercury. Normally leukocytes are less than 5, and single polymorphonuclear cell is abnormal. So normally less than 5 WBCs are present, and they are 100%. They should be lymphocytes. Even presence of one polymorphonuclear cell or one neutrophil is pathological, and you have to consider the chances of meningitis. In newborn, the limit has been increased up to 20. So in newborn, 20 cells should be present, and again all those should be lymphocytes. More than 75% should be lymphocytes in that. So less than 5 in pediatric and more than 20 in newborn. Then what is the normal protein? That is 20 to 45 milligram per deciliter, and glucose is 75% of serum. So it turns out to be more than 50. So more than 50 milligram per deciliter, more than 50. Okay. So these are the normal findings. Now, what do you see in bacterial meningitis? So in bacterial meningitis, the pressure is increased. The PMN predominant picture and WBC may be 100 to 10,000. Okay. So this PMN polymorphonuclear predominant picture, and they might be 100 to 10,000. And initially it is in a bacterial meningitis, if it is in acute stage, it is usually PMN. Later it might convert into mononuclear cells. Okay, protein is between 100 to 500, and glucose is extremely decreased. Okay, it is extremely decreased in patients of meningitis. Now partially treated bacterial meningitis, so it might have normal or mildly increased pressure, because partially it is treated, but the cells are rarely more than 1000, and they are between 100 to 1000 only. Usually after you treat, WBC fall off rapidly, extremely rapidly they fall off. So it is decreased, but again the protein remains the same and glucose normalizes or it is mildly decreased. So that are the findings of partially treated bacterial meningitis. Now, viral meningitis. See, in viral, you always have to consider that viral meningitis never occurs in isolation. It usually occurs with encephalitis. Okay, so viral encephalitis might be present or viral meningoencephalitis. There is no viral meningitis present, or there is no terminology like that, or if it is there, it is wrong. So for this, the pressure is mildly increased and the cells are between 100 to 1000 again, but again lymphocyte predominant. Okay, there are only a couple of examples in which the WBC count may be more than 10,000 in viral, and that is lymphochorionic meningitis. So in only that condition, but mostly it is between 100 to 1000. And in early stages or first to second day, there might be neutrophils, but later on lymphocytes predominate. Okay, the protein is between 50 to 200. It is comparatively lower compared to bacterial meningitis, and glucose is normal, but it is decreased in mumps. So the exception to the viral rule of meningitis is that in mumps, the mumps is the only viral meningitis with decrease in glucose. Rest all have very negligible fall in glucose. Now for tuberculous meningitis, okay, for tuberculous meningitis, the pressure is elevated and there are 10 to 500 cells. And again, there are mononuclear, but when you see the protein may be as high as 3000. And what happens in tubercular meningitis is many patients develop hydrocephalus due to this so much protein blocking of the ventricle outflow. So in TB meningitis, the steroids are very important because it decreases the protein and it decreases the chances of complication to hydrocephalus, along with the other benefits that it decreases the lipoic acid or mycolic acid that is released by the tuberculomas, which in itself are very toxic. So that is how in tuberculous meningitis you see. And in tuberculous meningitis, again the the CSF glucose is very low. Then other causes are fungal, syphilitic, and one of the important one that nowadays they are focusing on is amoebic, and the only amoebic, there are two amoebas that causes meningoencephalitis. One is primary amoebic encephalitis and other is granulomatous amoebic encephalitis. Primary amoebic encephalitis is caused by Naegleria fowleri. Okay, Naegleria fowleri. And granulomatous is caused by, please comment down below if you know. If you don't know, I'll tell you, it is acanthamoeba. It also causes corneal ulcer, the lens one that you might have read in the ophthalm. So the acute one, amoebic encephalitis, the pressure is elevated and the WBC count are 1000 to 10,000 and PMN predominant it is, and the protein is 50 to 500 and glucose is normal. Okay, so how do you diagnose this? You have to do a wet mount of the CSF and you see the parasites flowing like this. And the drug of choice in this condition has been historically been told to be liposomal amphotericin B, but again the efficacy, 50% of the patients with Naegleria fowleri die. So 50% mortality we have in patients with infected with Naegleria fowleri. But the newer drug that has now come, which was we used in Kala Azar, called as miltefosine, it has shown a very promising result in treating patients with amoebic encephalitis. So you have to keep that in mind. Now there are also other causes of encephalitis like autoimmune encephalitis. Autoimmune encephalitis is diagnosed by presence of anti-NMDA. NMDA is a type of glutamate receptor. Anti-NMDA receptor antibodies, if you find, then it is autoimmune encephalitis. Again, it is non-infectious encephalitis. If someone asks you that what are the non-infectious causes of meningitis or encephalitis, then it is sarcoidosis. This is over. Okay, sarcoidosis. And autoimmune disease like SLE. SLE is a common cause, and tumor, leukemia. Then ADEM, acute demyelinating encephalomyelitis, and autoimmune encephalitis. Okay, so what is ADEM? ADEM is a type of autoimmune encephalitis which usually occur in pediatric population after a viral infection, and it is usually an autoimmune reaction. And this autoimmune reaction causes demyelination in certain areas of the brain. And when you do an MRI, you see areas of demyelination, and there is global involvement of brain. Okay, so you have to keep that in mind. Now there is one named encephalitis known as Binswanger's encephalitis, and it is seen with measles or SSP. The complication that you see in patients, oh sorry, spelling is grossly wrong for encephalitis. So it is seen in SSP. It is an autoimmune reaction, and it is a Binswanger's encephalitis, and it is also seen in SSP. So this is one of the questions. Now, as we have seen that what usually you see, what are the pictures of the meningitis. Now you have to keep in mind that what are the most commons. So most common cause of meningitis. Now let's see what are the most common cause of meningitis. So in newborn or the first week of life, it is Streptococcus agalacti. Okay, Streptococcus agalacti. Okay, this is the answer that group A Streptococcus, group B Streptococcus. So Streptococcus agalacti. Okay, then in children it is Neisseria. In adolescent, again Neisseria is more common, and in overall, if you see pneumococcus, streptococcus or streptococcus is the overall most common cause, or it is most frequently identified. So if anyone asks you most common cause of meningitis in pediatric population, it is pneumococcus. Okay, Neisseria is more seen in adolescent population. So that you have to remember. There is also a specific cause known as Listeria monocytogenes, which is seen only in the newborn period, and it is usually not seen in the later period. It usually only causes diarrhea in the later period unless you are severely immunocompromised. So Listeria causes meningitis in newborn. It is a cause of meningitis in newborn. And one thing you have to remember is that cephalosporin do not have any efficacy against Listeria. They are inherently immune to cephalosporin, so you have to give ampicillin for patients of Listeria. So you have to keep that in mind. Now, for CSF, we'll see some specific organisms causing the bacterial meningitis. So first is strep pneumoniae. So for strep pneumoniae, we see that it has decreased incidence after the PCV13 vaccine we have used. So there are two types of vaccine that we used, three types actually, but the two most common types used in India are the PCV10 and PCV13. PCV7 is not preferred nowadays. So what happened was that after PCV7 came or PCV10 came, the other serotypes which were not covered by the vaccine flared up, and they became commoner causes of meningitis in patients who are vaccinated with the vaccine. So this is PCV pneumococcal conjugate vaccine, and what are the risk factors for streptococcus pneumonia? So it is otitis media. Otitis media is a very common cause of complications or CNS infection in pediatric patients. So otitis media, mastoiditis, sinusitis, and pneumonia itself. TSF, rhinorrhea or otorrhea. Rhinorrhea or otorrhea, it gives direct, way for the bacteria to go inside the brain. Presence of cochlear implant and immunosuppression. And two common other causes that you have to remember are HIV and sickle cell disease. So even these are the risk factors for infection with Streptococcus pneumoniae. Streptococcus pneumoniae is overall the most common cause of meningitis. And initially it was thought that you give penicillin or you give rifampicin as the prophylactic treatment against patients who have been in contact with meningitis. But many countries have changed their guidelines. Some countries say ceftriaxone, some countries say ciprofloxacin. So it is variable. The prophylactic treatment for meningitis is variable. And I'll tell you, in USA, they tell that ceftriaxone. In Harrison, it might be ceftriaxone, but in UK guidelines, they say ciprofloxacin. Rifampicin has been fully phased out for prophylaxis for meningitis. That you have to remember. Now, Neisseria meningitis. So, Neisseria meningitis usually causes, epidemics, local epidemics, and serogroup A is the most common in this, serogroup A. And please comment down below which serogroup is not covered in meningococcal conjugate vaccine. So, please comment down below and I'll upload the right answer. Again, meningococcus occurs more in winter months, and it occurs in usually, close clustering of families. Clustering of families, and less than 5 years is a risk factor for the patients for pneumococcus. And if there is a history that entire hostels of patients that there is a school hostel and entire hostel has meningitis, then it is usually Neisseria meningitis, because it is so virulent, and the highest infliction rate or highest involvement rate is with the adolescent age group. The third one and the uncommon one is Haemophilus influenza. Now with influenza vaccine, Hib vaccine, we have been seeing less and less cases, and it was initially very common, but it is usually now seen with the unvaccinated patients. And many times, they ask that what one of the complication of meningitis is sensory neural hearing loss. Now, historically, it has been said that it is occurring with Haemophilus influenza B, but the risk is also higher with Streptococcus, and the prevalence of Streptococcus is also higher. So, if there is any question associated that which meningitis causes deafness, then the answer should be preferred as Streptococcus, because the chances and the risk are also higher, and the prevalence of Streptococcus meningitis is also higher compared to Haemophilus influenza B. Another controversy that might be there, that should we give steroids before in all patients of meningitis before starting antibiotics? So I'll tell you the answer. The answer is yes. All patients of meningitis should be given steroids at least 1 hour or 30 minutes before the starting of antibiotics, which decreases the complication rate, and you have to only give for 48 hours, not more than that. And if you give 48 hours, you do not have to taper the doses of steroids. So if you have given more than usually 7 days to 10 days, you have to taper off steroids. But if you given for 48 hours, you can stop it. But you have to give steroids, and multiple studies have shown that steroids are extremely beneficial in patients of meningitis. So what are the complications or the pathology of meningitis? So first is increased ICP. We all know might cause blockage, it might cause cerebral edema, it causes inflammation. So there is increased ICP. There is SIADH. It is usually historically more seen with patients of tuberculous meningitis, but it may be seen with all of the patients. So SIADH may also be seen. Hydrocephalus is a common occurrence in patients whose the sutures are open. So the fontanelles are present and the sutures have not closed. So in these patients, hydrocephalus is common if you do not treat timely and if you do not treat with steroids. So this is important. It might also cause winding of sutures in the patients whose sutures have already closed. So this is the three common complication. Other complication, as I told you, is hearing loss, and it is sensorineural hearing loss, not conductive hearing loss. Now next, what are the clinical manifestations? So we have seen everything. Just the extra thing that I would like to tell you, that meningococcemia may cause something like Watterson-Frederick syndrome. So Frederick-Watterson or Watterson-Frederick. So what happens in this is there are signs of Addison's disease, and there is presence of rash or petechiae in meningococcal meningitis. So this rash is, a pathognomonic feature of meningococcemia, and it might be complicated with Addison's disease. Now, the most common cause of Addison's disease is tuberculosis infection. So, for chronic Addison's disease, the most common cause turns out to be tuberculosis infection. In acute, you might suspect meningococcemia, or you might suspect algid malaria. So, you have to keep that in mind. Now, Kernig and Brudzinski sign. Kernig is flexion of hip. Flexion of hip, and Brudzinski is flexion of neck. So in Kernig, what happens when you do neck flexion? There is passive flexion of the neck, and in Brudzinski, there is active neck flexion by you. It causes the passive flexion of the hip. So you have to keep that in mind. Now, lumbar puncture is the most important avenue in patients of meningitis for the diagnosis. So what are the contraindications to lumbar puncture? Then the absolute contraindication is local site infection. Okay. So this should not be there, and there are relative contraindications. So what are relative contraindication? Relative are increase ICP, but in this you can do something known as guarded LP. So if you do guarded LP, you can do you might decrease the chance of herniation of the brain. The other contraindication for the patients of relative contraindication is thrombocytopenia less than 20,000. Thrombocytopenia. So this is another contraindication for lumbar puncture. Now, if lumbar puncture is delayed, do not delay the antibiotic therapy. That you have to remember. Okay, you have to begin the antibiotic therapy as soon as possible. You do not have to delay the antibiotic therapy if you are planning. If you're waiting for, if you do not have to, keep the antibiotics waiting while you wait for lumbar puncture. Now, there are some important things that might be asked. So, what is the two questions that might be asked? First one is that, which parameters are unchanged with antibiotics. So what happened is that you give antibiotics, okay, and this antibiotic you have given for 2-3 hours, and after that you do a gram staining of the CSF. The sample is taken 2-3 hours after the antibiotic administration. So what parameters might change and what parameters might be same? So what parameters might be unchanged are that, gram stain will be negative, and what else would be unchanged is that the glucose might be normal. Glucose might normalize, but the WBC and protein content remains same. Okay, so culture becomes negative and glucose is low. So three parameters that are unchanged by the antibiotic administration are WBC count, that is again neutrophil predominance. The protein does not change immediately, and glucose does not become normal immediately. It takes up to a week to normalize. But if you do gram staining for the patients, or if you do culture for the patients, it might turn out to be negative. So you have to keep that in mind. Other thing is which parameters are unchanged. Parameters are unchanged with traumatic LP. So you did a lumbar puncture and you punctured a artery. So which parameters are unchanged in a patient with traumatic LP? So the three parameters that are unchanged are gram stain, this culture, and hypoglycorrhea or low glucose. So three parameters that are unchanged with antibiotics are WBC count, the protein content, and the glucose content. And the three parameters that are unchanged with traumatic LP are gram stain, culture, and hypoglycorrhea. Okay, so these both have three parameters, so it might be asked routinely. So you have to keep that in mind. There are specific investigation. Now for India, the most common cause of meningoencephalitis, some authors say herpes, some authors say Japanese encephalitis. So I would be very guarded on this. I will not make an comment which is the most common cause in viral. But again, you have to make the diagnosis. Viral serologies are important for CSF. For tuberculosis, you have to send CSF for CBNet. That the same thing that we do with sputum. We do PCR of the mycolic acid for the diagnosis of tuberculosis, and we do gram staining for the presence of overtly if the bacteria are present. And there are some other specific investigation like CSF serologies or CSF staining or the negative stain for cryptococcus, or for patients of syphilis. Then again we will do negative staining with India ink. So all that specific investigation, according to the organism that we might think that might be involving, we have to send. So what is the treatment for the patient? So for treatment, what do we do? So for the treatment, we have to keep in mind that ceftriaxone is the empirical treatment, and you have to add a vancomycin if you think that Staphylococcus aureus is also involved. Usually oral antibiotics are not preferred in patients, and if ceftriaxone vancomycin do not improve, then we might start with meropenem. For the patients with herpes, we have a treatment, we call it as acyclovir, so we can give acyclovir. Now the important part comes over here is what is the duration of treatment. So you have to remember, for gram positive organisms you have to give for 14 days. For gram negative you have to give for 21 days. Okay, so 14 is the lower limit. At least 14 days, you can give up to 21 days, and for here it is 28 days. But if they ask you, then it is 14 days, here it is 21 days. And the least amount of treatment is required with Neisseria meningitis, which require only 5 to 7 days of antibiotic therapy. It has the minimum dosing or the minimum duration of antibiotic therapy amongst all the patients. Again, this 14-21 might be a controversy, but it is not. In Nelson, which is the standard textbook of pediatrics, it is given 14 to 21, and it is also given in the standard textbook of newborn, that is known as Avery's disease of newborn. So you have to keep that in mind. And with this, the important thing I will tell you is that you do not forget Dexona. Dexona is the steroid of choice that we use in patients of meningitis. And with that out of the way, I guess that's all for today. And I hope you like the video. If you like the video, please comment down below and like, share, and subscribe to the channel. And I'll see you in the next one.